All right, fantastic. Thank you so much. And thank you all for joining us here today. I told Adele I would introduce myself because I always think it's helpful to give a little context, especially when I'm talking about this particular patient population, our LGBTQ plus patient population. So I did my training in OBGYN. I did my residency at the Medical College of Wisconsin from 2007 to 2011. And then after that, I went to Baylor College of Medicine in Houston for a pediatric and adolescent gynecology fellowship. As part of that fellowship, we had a clinic where we managed a lot of hormones. We did a lot of puberty induction, not necessarily for the LGBTQ plus patient population, but for patients who otherwise were not going to proceed through puberty in a typical fashion, patients with Turner syndrome or differences in sexual differentiation, intersex conditions, things like that. So I ended up at that time getting a lot of experience with hormone management, but no training for this patient population, which was not uncommon at that time by any means. So when I returned to MCW for my practice in 2014, I was practicing generalist OBGYN care as well as pediatric and adolescent gynecology. And one of the partners in our OBGYN office was doing LGBTQ plus care kind of in isolation as part of her adult practice. It was a passion of hers. She had also not received any formal training. She was going to be moving to Minnesota with her husband, and she just asked me, "Hey, would you be willing to take over care for these patients? I don't think there's somebody else in the department who would be comfortable doing that because not a lot of people have training just specifically in hormone manipulation and in puberty induction." So I said, "Sure, absolutely. Why not? This is a totally reasonable thing for me to do. I feel qualified to do this in spite of having had absolutely no training whatsoever. I didn't want those patients to not be getting ongoing care. And at the time, we didn't have anything organized at MCW. So I kind of took over her patient population and just was learning as I went, which is obviously not ideal. And then in 2018, Medical College of Wisconsin opened up the Inclusion Health Clinic, which is an amazing multidisciplinary care clinic for this patient population. It has been a tremendous asset to the community and to our healthcare system. But I just kind of wanted to give you that outline because I think it is incredibly common that healthcare providers did not receive any formal training, especially if you're kind of mid-career like I am. There are probably some providers and healthcare workers who are earlier in their career who may have had some formal training, but most of us did not because it wasn't a part of a formal medical school curriculum, wasn't a formal part of residency curriculum, and at the time there were not fellowships, especially for outpatient care. Certainly a handful of surgical fellowships, but not for otherwise gender affirming care. So I think that that's just an important nuance for providing care for this patient population. Important to know as we talk about this because most of us who are providing this care were not trained to do so. And that translates in the care that we provide, interestingly. So, objectives for today are to kind of identify some historical barriers to accessing care for the LGBTQ plus patient population, to identify some basic principles of trauma informed care and how to apply them more specifically to this patient population, and then to discuss implementation of concrete strategies to improve trauma informed care practices in your own interactions with LGBTQ plus patients. So the first thing I want to do is if you're able to join this poll, we can give a couple minutes here. I just want to see if you can tell me what percentage of your patient population identifies as a member of the LGBTQ plus population, just so I kind of have a sense of where we're at. I know for me, it's about 75% of my patient population because I still have a cohort of my pediatric and adolescent population, but all of the adult patients that I see are through our inclusion health clinic. I don't have a generalist OBGYN clinic anymore, so all of my adult patients are in this patient population. So I'm hoping that sorry, that's me. I'm hoping that you're able to access this and we can see some responses.
And it looks like I'm trying the QR
Oh,
code. I can tell you
we
if it
go.
works.
Perfect. I'm always get confused because when I can see like the thumbnails if something's blocked, I'm hoping you don't see thumbnails as well. So hopefully you can see that
Oh, yeah.
QR.
Yeah, the QR
Fantastic.
code worked for me for anyone who's trying to figure out the best way to do it.
Great. Great. Okay. Okay, this is good. We have kind of a range. And it's not unexpected. I wouldn't expect that anyone is in that 75 to 100% range because most places don't have a built-in structure where you have an exclusive LGBTQ plus patient clinic. We're fortunate to have that. And I do have some partners who fall into that category, but even I personally don't because of the remainder of my practice. So this is good. So we're seeing kind of a range here. So it's good to know that we have people who have some experience taking care of this patient population. And then it's also not surprising to see some statistics of I have no idea because it is not always that patients are disclosing this to their healthcare providers. And that's an important nuance as well. So just going to review a little bit of language. There is so much language out there and so much terminology that you can use in and outside of a healthcare setting. But one professional organization that kind of sets standards very specifically for transgender health, which is where we get a lot of our data, kind of recommends some language. So transgender and gender diverse, so TGD represents a broad group of individuals whose gender identity is not consistent with their sex assigned at birth. That is kind of broad terminology embedded within the LGBTQ plus terminology. And it's important to note that gender dysphoria refers to discomfort and distress that is caused by a discrepancy between a person's gender identity and that person's sex assigned at birth, and can also be associated with gender role and or primary and secondary sex characteristics. So important distinctions. And then some additional terminology. Gender affirmation refers to the process of recognizing or affirming people in their gender identity. This can be socially, medically, legally, behaviorally, some combination. It's important to note that gender affirming care is not synonymous with transition related care. Providing transition related care doesn't even ensure that you are providing affirming care or implicate quality or safety of the care provided. And certainly that is for transgender and gender diverse patients, but also for patients who identify as gay or lesbian or bisexual or intersex. All of those things kind of fall under that umbrella. So, not even just gender affirming care, but just affirming care in general. Gender incongruence is a condition in which the gender identity of a person does not match the sex assigned at birth. And gender incongruence does not necessarily imply gender dysphoria if there is no associated distress. So I'm outlining these specifically because within the LGBTQ plus community, it can be the most challenging to provide comprehensive care to patients who identify as transgender or non-binary because we are just less familiar with that in general. I think most people can recognize that okay, if someone identifies as lesbian, they essentially get the same primary care, they get the same GYN healthcare, they should get all the same screening. Same with our patients who identify as gay or bisexual. But when it comes to providing transgender care, that can be a little bit more challenging. So when we look at the overall LGBTQ plus experience and some of the data, we know that almost 50% of patients report sexual assault as adults. And there's also a large percentage that report sexual assault as minors. About 32% report physical assault by a partner, 35% postpone medical care due to disrespect or mistreatment, and almost 50% had to teach their provider how to care for them, whether it be primary care, specialty care, surgical care, all of those things. Many LGBTQ plus patients and people will report traumatic experiences caused by healthcare systems. These can include misgendering, invasive questioning, denial of care or discrimination, and all of these can re-traumatize our patients because in most of those instances, we don't know what has been their historical context, both in and outside of the medical community. And lack of provider knowledge increases this burden. And that is a really significant point. And that's why I kind of told my origin story in the beginning, because when we are learning as we go as providers, our patients, they sense that and they know that, and we need to be transparent about that. But it obviously makes it a little bit more challenging to, oh, am I still sharing? I don't know what I just did. To be able to find trust in that healthcare system. And so we just have to be mindful of what patients' experiences have been in and outside of the healthcare community. I also want to point out, I'm just going to give a little bit of information from a national survey that's been conducted a couple times in our country, but I didn't touch on these points with this data, but what the information that we have does show is that patients in the LGBTQ plus community face discrimination at home within their families of origin with a chosen partner or friend group in religious establishments, in schools, within the legal system and law enforcement, and also in healthcare. So if you think about in our society, where are the places that people should feel safe? These are places where this population has identified that they cannot reliably feel safe. And so it may be that some people have a great experience and some people have a very poor experience, but overall, we need to be mindful of the fact that these are not safe spaces for people in the way that as a, you know, cis white heterosexual person, I would expect to feel safe in these community-based organizations and home-based places. That's not the case for everyone. So I'm going to give a little bit of information from the 2022 US Transgender Survey. This is a survey that has been conducted a couple times, and this is the most recent survey. So it is the largest in the US. It's administered online in English and in Spanish. It's open to binary and non-binary people ages 16 and older. The previous surveys have only been open to patients 18 and over. So this was just a little bit of an expansion of that. And this includes people who are living in the US, US territories, and on US military bases. So this data was collected between October and December of 2022, and data was collected from over 84,000 adults and then an additional 8,000 plus for patients ages 16 and 17. The findings that I'm going to talk about today are just in adult respondents, but just to demonstrate that we're trying really hard to get information from people about what their overall experience has been. And data was collected from all 50 states, the District of Columbia, 5 separate US territories, and overseas military bases. This is a super extensive document. I'm clearly not running through all of it, but just want to highlight a few key points. So, a few key points here: 98% reported substantially higher levels of happiness, thriving, and satisfaction after they had received inclusive health care. And among those that had accessed gender affirming hormones, 98% reported higher satisfaction with their lives. And among those who had accessed gender affirming surgery, 97% reported higher satisfaction with their lives. And we're not only talking about patients who are receiving, gender affirming care here today, but there is so much in the media and so much information and misinformation being spread throughout our social media and news outlets. So I just think it's important that we all know that when information is collected directly from the source, from people in our country who are receiving this care, the majority of them are having a very good experience. So you'll see information in the media about, the perils of gender affirming care and providing inclusive healthcare in an inclusive healthcare setting. But overwhelmingly, the information suggests that this is positive, it is necessary, and it is improving people's quality of lives in our country. So some key points about health. About 66% of patients who answered this survey reported their health as excellent, very good, or good, and that's compared to 81% in the general population. 34% rated their health as fair or poor, compared to 18% in the general population. So a pretty significant difference there. 81% reported feeling down, depressed, or hopeless at least several days over the past 2 weeks, and that's compared to 57% in the general population. And so key points about experiences specifically in a healthcare setting. About 79% had visited a healthcare provider in the past year. This was similar to the data that was presented in the previous survey, which was in 2015. So that's great. About 50% said their providers knew of their gender identity. 47% experienced at least one negative interaction with a healthcare provider. And these generally, kind of like I had mentioned before, include misgendering, using wrong pronouns, using a patient's dead name or previous pronouns, asking invasive questions that aren't necessarily related to the reason that the patient is there for the visit, but have more to do with their sexual orientation or gender identity. Non-binary people who are assigned female at birth and trans men reported the greatest proportion of negative experiences with a provider. And about 55% of respondents with a disability reported any negative experience with a healthcare provider. So that's important as we think about certainly intersectionality. That is to me, this is a very complicated concept. This is a really complicated illustration of how people who identify as a member of the LGBTQ plus patient population, if they have any other um, differences that would be considered departures from a power status. So if they are not white, if they have a low level of education, if they are not able-bodied, if they are not heterosexual, if they're not neurotypical, if they don't have really solid mental health, if they don't have a slender build, if they aren't property owners or considered wealthy, if they don't speak English, if they are not a cisgendered man, if they're not a citizen of our country. These are all things that kind of exacerbate the negative experience that people have in our community, in our world, but also in a healthcare setting. So we also have to think about the notion of minority stress and systemic oppression and how what is the impact for these people of chronic exposure to stigma, discrimination, and rejection. LGBTQ plus people of color face significant compounded risk, and about 60% of LGBTQ plus hate violence survivors are people of color. So these are things that we have to be mindful of when patients are walking into our office. And as we think back to that first slide, some of us have kind of a general idea of what is the percentage of our patient population that identifies as a member of this community, but almost certainly it is higher than we even know. And so it makes total sense that some people identified that they don't know because sometimes it's not coming up. If you are not the primary provider that's going to be seeing the patient in that clinic visit, for people who are rooming the patient, people who are collecting vitals, people who are scheduling, people who are learners, people who are coming in just for an educational component, this may not be information that you're collecting, but it certainly impacts the patient's experience in the healthcare setting. So we've kind of talked a little bit about the patient population, and of course, we're also tying that into talking about trauma. So trauma is an event or series of events experienced as physically or emotionally harmful or life-threatening. This can lead to lasting adverse effects for emotional, social, physical, or spiritual well-being. Trauma, this is a really important piece. Trauma is defined by the person's response, not by the event itself. So you may have had a traumatic experience at some point in your life, but at the end, the outcomes were good and you took away a lot of learning from it and you banded together with your community and everything was better in the end. So you can identify that initial piece and then something really positive and some flourishing that came out of that experience. That is not everyone's experience. So if someone reports that they had a similar experience and you're thinking, oh, we can identify in this way, or, we can, I can have some empathy through this experience. We can never make any assumptions about a person's response or whether or not it resulted in trauma for them. Similarly, something that may have traumatized us may not have been traumatic to one of our patients, even if they had a similar experience. So we have to be really careful not to project how we have interpreted our own experiences or experiences of other people that we know or are close to, and how they would similarly impact patients that we're interacting with. So acute trauma is a single event that can certainly lead to lasting impact. Chronic trauma consists of repeated events over time. Both of those can have the same long-term impact regardless of the duration of the experience. And then, of course, there are more complex areas of trauma that can consist of early and ongoing trauma, often involving caregivers. And again, exacerbating the experience for patients in our LGBTQ plus community because we've already identified that they cannot always find safety in places where we assume people are safe. Religious establishments, law enforcement establishments, educational establishments, all of those types of things. And of course, we have to think about PTSD. So whether somebody had an isolated traumatic experience or a chronic traumatic experience, the effect of that can last for months or years. This doesn't have anything to do with the LGBTQ plus patient population, but when I was in Houston, in my training, I would take my dog for a walk every single day. And every day I would encounter the same homeless man. And every single day he would say, "Excuse me, ma'am, can you tell me if there's smoke on my back? And every single day he would turn and I would look and I would pat him on the back and I would say, nope, everything looks good. You're perfectly fine. You're safe. And he would say, thank you. Have a great day. And he would keep walking. And I didn't get to know that man. He was clearly not well. But all I could think was, I have no doubt this man has military trauma and he is suffering PTSD. And it was just the saddest thing just to think about, how experiences can impact people for their entire lives. That is a whole separate issue when we think about our veterans, but PTSD is very, very real. People experience it very differently. So we have to be sure to not dismiss that. So some of these symptoms can include flashbacks, hypervigilance, avoidance, anxiety, sleep disorders, hopelessness, memory problems, detachment, feeling numb, suicidal ideations or attempts. And certainly I have to be very mindful in my line of work because I do gynecology. So I'm doing a lot of very invasive work. So I have to be very careful about making sure that I'm not re-traumatizing patients. The hallmark PTSD symptom of avoidance of reminders of trauma leads people to avoid mental health treatments, many of which will require focusing on trauma and oftentimes which result in the use of medications that can certainly improve people's overall health and wellness, but can also often leave them with a feeling of being very flat or feeling numb to emotional stimuli that can be very uncomfortable for people. So we can understand why PTSD proves to be so very hard to treat because oftentimes the treatments are just not feasible for patients or require an incredibly long relationship buildup in order to establish that rapport and trust to be able to get through that treatment. And of course, we all know mental health resources are very limited and stretched very thin in our society. So that can be very challenging for patients to navigate. So when they're coming to see us for these brief interactions in a healthcare setting, they may be bringing with them this trauma that has been poorly treated, undertreated, or not treated at all due to some of these barriers. So, what is trauma informed care? Most of you, I'm sure, are aware of this, but it's just a framework that kind of recognizes the 4 R's, realizes the widespread impact of trauma. Most people have experienced some form of trauma, whether it has had a lasting impact or resulted in any PTSD, we don't know, but most people have encountered trauma somewhere along the way. We need to recognize the signs and symptoms of that. We need to respond by integrating trauma knowledge into our practice and really try hard to resist re-traumatization. That is hard in a healthcare setting. We are pressed for time. We are pressed for resources. We are encouraged to be incredibly efficient in a healthcare system. That does not lend itself to not re-traumatizing our patients. It is very challenging. So how do we try to include and expand these to our LGBTQ plus patients? These are obviously very broad principles, but we want to be able to kind of hone those in. So when we think about physical, emotional, and cultural safety for our patients, we may have to adapt some things about the way we provide care. For instance, this is controversial, certainly, and we know within the GYN and the primary care community, there are some methods by which the FDA has approved for self-collection of PAP and HPV screening. So we don't have access to that at our clinic, but we do allow patients the option for a self-collect PAP screen. And we think that that's really important for their psychological safety so that they feel that they are safe in our healthcare setting. This affords them the opportunity to avoid a pelvic exam if they don't need one, to avoid a speculum exam, so they can get all of their STI screening and their PAP screening without having to have a provider do an invasive exam. That is a really important and very appreciated aspect of the healthcare that we provide. Trustworthiness and transparency. It is important for our patients to know what is going to happen in a healthcare encounter. So I tell patients the second I sit down with them, if it's my first time meeting them, if you do not want an exam today, you are not going to have an exam today. Today, we can talk, we can get to know each other. I want you to feel comfortable in this setting. If you have something acute that requires that I look at it, absolutely, we will do that. But I also want you just to kind of get the lay of the land and feel comfortable in this setting. And most of my patients will breathe an audible sign of relief, and you can see the discomfort drain away from their faces, because that feels very invasive to meet someone for the first time and have to have an exam. So for this patient population, I find it very important for them to know we don't have to do that here today. Peer support. So recognizing that patients may or may not want support through any type of a clinical encounter. Sometimes if we are going to need to do something invasive, I'll say, do you have a support person that you want to be in here with you? Or do you not want to include that person in this type of an exam? We can have one of our clinic support staff come in here and be support for you. And so patients will oftentimes kind of give us some context about what they want, and we can be very flexible there. So collaboration, we have to work very hard to collaborate with our patients, with other providers, but mostly we want to make sure we understand what our patients' needs are, what they are there for, make sure that the care we are providing is consistent with what they're looking for, and we are not asking additional invasive questions that aren't necessary to provide the care we care. And when we do, to make sure that we are clarifying why. I have to do that a lot, as you can imagine. Empowerment, voice, and choice. We are giving patients a voice to say what it is that they need, what has been their previous experience, what kind of language do they prefer that we use, what are they willing to do today, and what do we need to defer. If a patient is due for a PAP screen, I am never going to say, oh my gosh, you have not had your PAP, you were due last month. We absolutely have to do this today. This is a non-negotiable. I will say, hey, I just want to put it on your radar. This is something that we need to do. I want to make sure that you are getting the same standard of care as everyone else, and this is the standard of care. So at some point in the near future, I want us to do this, but I want you to put that on the back burner right now if you were not prepared to do that today. I'm giving them a choice. And sometimes they'll say, you know what? I knew I needed to get that done. I've been prepping myself for months. Let's just get it over with. Great. And if not, if they're like, oof, I just don't have it in me today, that's okay. We'll set up close interval follow-up. We'll see if you're feeling ready. We'll do what we can to get you prepared in between now and then. And then, of course, this should go without saying, but always we remind ourselves cultural, historical, and gender humility. Just recognizing that everybody is bringing a completely different experience to the table. People's historical context you are not going to know unless you ask, and we definitely cannot make assumptions. So that's just an important reminder for all of us as we go into every single clinical encounter. So what do we need to do as healthcare providers? The concrete things that we need to do to provide good care for the LGBTQ plus patient population is definitely use correct names and pronouns consistently. This is one of the things that people identify the most is bothersome. And this can be a moving target. This is evolving. People's experience can change between different visits. And so it can be very hard to keep up with, but we try really hard to utilize the resources that we have to make sure we're navigating this correctly. At Froedtert, the medical college, we use Epic is our electronic health record. So everyone can see in the corner when you open up a patient encounter, you can see the patient's demographics. So sometimes you can see a picture, but you can see the patient's name. If they have a preferred name, you can see the preferred name. And if they have preferred pronouns, you can see the preferred pronouns. In our healthcare setting, we give patients the option to input that ahead of time so that it is visible to us and they don't necessarily have to be asked that information, but that may not be the case everywhere. And it can be hard to get used to asking, but it's just something that if you practice, you can incorporate into your interactions, regardless of what that interaction is going to be. You can say, hi, I'm Dr. Francis. You can call me Jessica or Dr. Francis. What would you prefer that I call you? And then that's just kind of an easy way to start that conversation. Most of us on our name badges will have a like pronoun pin or pronoun sticker. Most people will notice that and kind of recognize, okay, this is kind of a safe space to have that conversation. So making it obvious that you're open to those conversations is also helpful. Sometimes if my badge is flipped over or, I'm not in the same setting or the same attire that I normally would be when I'm encountering a patient, patients don't necessarily offer that information up. But usually if I have my pin on and my sticker, they'll say, oh, I like your pronoun pin, or, and it just kind of opens up that conversation. So there are ways to make it visible that we're open to those conversations and that we're open to providing inclusive care. So, avoiding assumptions about identity, partners, or bodies, I think is very, very important. It may say in the demographics that someone identifies as lesbian. We can never assume that means they have never had sex with someone who is assigned female at birth or assigned male at birth, or that they don't participate in that activity, or that they are in a monogamous relationship, or that they are having sex with multiple partners. We just can't make any assumptions. And so it puts us in a tricky position because then we are asking a lot of questions and trying to figure out what is that balance of asking enough questions that I can provide comprehensive care, but not asking so many questions that at some point it just feels invasive and voyeuristic, because people do identify that's one of the most uncomfortable things as a member of the LGBTQ plus community trying to get care in a healthcare setting, is feeling like they're being asked questions and they're like, why do you need to know this? So sometimes I'll ask a question and then I'll say, the reason this is important is because this helps me know what areas of your body do I need to screen for sexually transmitted infections. Because we can do oropharyngeal swabs, we can do vaginal swabs, we can do penile swabs, we can do rectal swabs. And we want to make sure that we're keeping your whole body healthy. So that kind of helps rather than just say, do you have oral sex, vaginal sex, or anal sex, or all? Like, that's like, whoa, that's a super invasive question. Why do you need to know that? And sometimes you can say, the reason I'm asking this is because this is how we screen. These are the areas we can screen. What areas would you like us to screen for you today? And so just kind of adapting some of that language. And then the tricky thing too is if you have patients who have had surgical intervention. So for our patients who identify as transgender, those are typically patients who are having surgical interventions. It can be hard to know if there's not an organ inventory in their chart, if they have had surgical interventions or not, and what organs are still present and what organs were they born with. But again, this is important information because if a trans woman comes into my office, I need to know if this is a trans woman, because if they have a prostate, then that prostate still needs to be screened. If it is a trans man and they still have a cervix, the cervix still needs to be screened. So we need to make sure that we're using language that sends the message. I am asking these questions because I want to keep you as healthy as humanly possible. And that means you get the standard of care for screening for any body part that you have. And so providing more information about why you're asking questions can really go a long way to help people feel like, oh, okay, they really want to take good care of me. They're not dismissing me. They don't want to not know because it's uncomfortable and then I don't get good care. I also had a patient once come into my clinic, and that this patient, this is our LGBTQ plus specific clinic, and that patient didn't even identify as a member of the LGBTQ plus patient population, but she had a degenerative neurologic medical condition and used a wheelchair. And she was 35 years old and said she had never had a pap smear or STI screening, and had never been offered that because everybody just assumed that because she used a wheelchair, she was not participating in any type of sexual activity. Somebody had actually put in her chart that she had been sterilized with an eSure device, which is a device that's no longer on the market. And she had no idea. She said, I don't know if that's something that my parents maybe would have done when I was young, or if I had that done, but that's not something that I consented to. So you can imagine, we talked about kind of intersectionality and all the ways that people can be denied good health care when we make assumptions just based on looking at people. So it's very important that we don't make any assumptions. And we normalize discussions about gender and sexuality. That is very easy for me to say because I'm a gynecologist and I work with a lot of adolescents. So I have a lot of conversations about sexual health and sexual safety and all of those things. But I've also been fired by an adult patient because they thought it was incredibly rude that I asked if they had any sexual health concerns, and that was none of my business. And so it can be really challenging to meet patients where they are. And so that's why just the language is really important to say, you know what, these are questions that I ask every single one of my patients. This is my job, and I want to make sure that we are taking care of everything that we can take care of here for you today. So offering choices to increase autonomy, I talked about that a little bit, not making somebody have a really invasive procedure the first time they meet you. There are very few things that are going to progress so rapidly or in a dangerous way over the course of a few months if you don't do a screening. And so obviously that's not true of everything. And there will be times where you'll need to make a very strong recommendation. But when that's not the case, you can offer some autonomy, you can offer some choice. We do this today, we do close interval follow-up, all that kind of thing. And then just trying to create a visibly affirming environment. That's really easy to do in a setting like I have, working in the inclusion health clinic. There is signage everywhere, there is artwork everywhere. It is the people who work there have chosen to work in that healthcare setting. Patients know that they are coming into an inclusive healthcare environment, but that may not be visible across an entire healthcare organization, and we totally understand that. So whatever you can do on your white coat, on your name badge, on your scrubs, whatever, or however you can impact your setting and your environment, I think is really important for patients. They see those cues, and it certainly makes them feel like they're in a safe space where they can engage in good healthcare. And then how can we reduce the risk of re-traumatization? I have to think about this a lot in my role, and I'm sure a lot of you do as well. Explaining a procedure before you touch a patient. I find pelvic exams, pap screens, IUDs, all those things where a patient is laying back in stirrups, that is an unbelievably vulnerable position for a patient to be in. So saying what you're going to do and kind of walking through the steps, walking through the touch, walking through the timeline, I think is very, very important. And obviously there are other invasive exams that people do as well, but I try to acknowledge ahead of time, like I recognize that your positioning and my positioning and the fact that you can't see what I'm doing is just an added layer of stress for this situation. So I'm going to do the best I can to make sure you know exactly what's going to happen. Asking permission and checking in frequently. We'll say before we start an exam, you're in charge of how this goes. If you need me to stop completely, you tell me. If you need me to slow down, you tell me, and I'm going to tell you what I'm going to do next so that you can prepare for that and let me know if it's okay to proceed. So we'll start with, okay, first I'm going to touch right here, and then I'm going to move further, towards the vaginal opening, that kind of thing. Providing privacy and control. That's a balance. Some people want to not have anybody else in the room, not have their support person there. Some people do want their support person there. We can't make any assumptions about whether or not they want that support person there, because sometimes if someone chooses to not have a support person there, that is an excellent opportunity to say, do you feel like you're in a safe relationship? Your partner, they treat you well, they treat you with respect, you have access to your money, you have access to friends. All of those things are important things. So we can use those opportunities when they choose to not have a partner there or a support person there to ask questions. And then avoiding unnecessary gendered language. This is challenging and takes a lot of practice. So, if I enter a patient room and I know I'm seeing patient X, will say, hello, so great to meet you. I'm Jessica Francis. We're so glad you're here today. And who do you have with you? And I'll gesture to their support person, because inevitably at some point I'll say, oh, is this your husband? Is this your wife? And that's unnecessarily gendered language. Who is your support person that you have here with you today? Okay, great. And then kind of let the patient kind of guide that conversation and what kind of language they want to use. And then even for me as a gynecologist, when I'm using language for exams and surgeries and things like that, it is hard not to use gendered language. We use words like uterus and ovaries and vagina and vulva and labia and things like that. That can be very, very hard for patients to hear. So it's sometimes important to have those conversations ahead of time. Like, how do you want me to approach this subject? But it is a very delicate balance. I will tell you, I recently had an experience where I was counseling a patient about surgery, and they had reached out to me via my chart ahead of time. And they said, here's what I need from you. I need the surgery to be offered in this way, and I need this to be what happens. I need to not have an exam at the pre-op consultation, and I need you to not use any anatomic language discussing body parts. And I was like, okay, I think I can make that happen. So I explained how to do a total laparoscopic hysterectomy without saying uterus, cervix, fallopian tubes, ovaries, or vagina. And I will tell you, I thought we had achieved absolute success. And then after the procedure, when the patient read the operative report, they were outraged that the organs had come out of the vagina. And that patient then told me over my chart, I did not know this was what was going to happen. If I had known this was what was going to happen, I would have elected to have an abdominal hysterectomy with an abdominal incision. And I was like, I'm so sorry. I was working really hard to tell you how this was going to happen and say things like the organs will come out from down below and trying to make sure you understood this as well as you possibly could. And at the end of the day, that patient ended up having a suboptimal experience because I didn't use the necessary language. So it can be really, really hard. And all we can do is try. Patients, in the end, they understand when we try, we're not going to nail it every time because, again, most of us have not received formal education on how to do this. And ensuring staff at all levels receive LGBTQ plus cultural competency training. This can be very challenging. It's obviously easier in a smaller setting. It is incredibly hard in a huge healthcare setting, which is part of the reason why at Froedtert in the Medical College, we did establish the Inclusion Healthcare Clinic. And when we established that clinic and we were doing some community advertising and working with community groups, we did have people in the community ask questions and say, you're calling this the Inclusion Health Clinic, but we're actually feeling like as a patient population, we're going to be excluded because just because I have a same-sex partner, now I don't get care in the general GYN clinic. I have to go to a separate clinic or, something like that. And, at the end of the day, we would love for everyone to receive fantastic care in every single setting. And unfortunately, that's just not the reality of the world that we live in. And it probably won't be for a while because we're just in that place where this type of care training is being incorporated into undergraduate medical education, into graduate medical education, into other training programs, whether it's ultrasonography or phlebotomy, all of those things. So it's going to be a while before we're there. But at least in the settings that we have control over, we can make sure that people are getting training and that people are motivated to provide inclusive healthcare. And that can be challenging. That is not consistent with everybody's career goals. That is not consistent with everybody's cultural beliefs or religious beliefs. And so we have to be mindful of that as well. And so, as much as we want to make sure that our patients understand what kind of care they're getting in a setting, we want to make sure that our providers understand what kind of care is expected of them. And that may impact if they choose to work in that setting or not. And that's a reasonable expectation. Okay, so we're going to run through a couple of quick cases. And these are cases that have actually happened to me in my clinic. I've changed the names. So, case number one, I get a call from Sal coming to the clinic. This patient's going to be coming to the clinic to discuss an upcoming visit and procedure, and they are requesting a phone call for me. I haven't met this clinic or this patient. I don't know exactly what they are hoping to get out of this phone call. All I can see is that they have seen a provider in our healthcare system in the past for GYN care. And so when I call Sal to say, hey, this is Dr. Francis, just wanted to touch base and make sure we're prepared for your visit when you come in. And the first thing they said to me was, if this doesn't go well, I am never seeking healthcare again. So immediately, this feels like a lot of pressure, but also feels like a really important opportunity because this patient has set the stage for like, I have something important to say. This clinical encounter is going to be pivotal for me. So let's work together to see how we can optimize this experience. So this patient identified as a trans man and was in need of a colposcopy due to a pap screening irregularity. The pap experience was very traumatic for this patient, and they received this care from a provider that I have known for a very long time who is an amazing healthcare provider. But this patient had a trauma history and needed probably more time to prepare for the pap screen, probably needed to have one of those encounters where we talk, get to know each other, and offer a follow-up visit for a pap screening, possibly with an anxiolytic, making sure they had the right support person there with them, all of those things. But this provider is a very high volume provider, likely did not have a lot of time to have those conversations, and it didn't translate well for this patient in terms of receiving additional care. So another element of that that's challenging is when you receive care in one healthcare setting and now you're being sent to another healthcare setting to get that follow-up care. So the really unfortunate thing about this is that Sal was being sent to me to get a colposcopy, and we do not have a colposcope in the Inclusion Health Clinic. So I'm like, ooh, this is going to feel really bad when I have to tell this patient that this isn't even something that I can offer here. So what do we know? Sal needs trauma-informed care, right? So when we're on the phone, we took the time, and this was actually nice because this was outside of my clinic time, so I had a little bit of time to do this. So I take the time to validate the experience. Sal tells me about the PAP experience. This might not have been traumatic to someone else who didn't have a trauma history and had had multiple PAP screens in the past and was like, okay, I'm just going to get in, get out, get on my way. This is a non-event. I'm going to come and go and it's no big deal. But that wasn't Sal's experience. And so I needed to validate that that sounds like it was a very challenging experience for you. Obviously, we can't do anything to change that, but we can certainly make sure that that doesn't happen again and that that's not your experience when you come in for your colposcopy. So then we talk about preferences. How can we make this the easiest for you? Do you want to plan to do this when you have a specific support person? We can allow for extra time. You can meet me in a clinic setting ahead of time. Do you want an anxiolytic? Oftentimes we'll offer people Valium as long as they know that they have to then have a ride and sign any consent forms ahead of time. And then making sure that we are transparent about what this procedure entails. Because again, a colposcopy is similar to a PAP. You can't see me. You are laying back with a sheet in stirrups, all these things. It's very uncomfortable. So kind of talking about what does this look like, about how long does it take, being honest about how uncomfortable it will be or downright painful, and then offering choices about support, choices about timing, choices about anxiolytics, choices about follow-up. Do you want this to be the first appointment of the day and then you take the day off from work? Do you want it to be the last appointment of the day so you don't have to miss a day of work? All of those things help to make sure that that patient feels heard and that we are working together to make sure this is a seamless experience. And then ensuring an affirming environment when they come in for this appointment. So this was tricky because now I'm like, I am so sorry to say this. You're coming to the Inclusion Health Clinic specifically to get inclusive healthcare, but we don't have a colposcope. So I will see you still, but it is going to be in the general OBGYN clinic, which can be very uncomfortable for trans men. And so we just kind of worked out ways like, okay, we can do this. We can make sure that you're not in the waiting room for a long time. I can be the person that comes out and gets you in the waiting room as soon as you arrive so that you don't have to wait to be roomed. They can do the rooming tasks after we're already in the room in terms of, collecting vitals and asking specific questions and all those things. So just kind of making sure that we set the stage for what that visit is going to look like. But then, so that's what Sal experienced when we were on the phone. But then behind the scenes, there were other things that needed to happen, right? So I had to provide documentation to the necessary people to make sure that we had what we needed on that day. So I'm contacting the GYN clinic, the front desk to say, here's how this is going to go. I need to know as soon as this patient arrives so I can come out and get them. And then I'll communicate with the MA because this is a departure from our typical workflow. And then follow up with any colleagues who are enlisted to help. I still do colposcopy, but in instances where I'm not able to go over there, these patients are going to a different colposcopy clinic with one of my colleagues who I trust, and I tell them her name and what will happen and all of those things. And then just following through with the details and the preparation. So individually reaching out, we're going to put this patient in this slot in this room for this procedure, and here's how this is going to go. And then making sure once we've closed the loop on all of that and that is all feasible, reaching back out to the patient to say, okay, this is how you wanted this to go. This is the experience that we are going to try to make happen on the day of. And so it requires a lot of work, but it is very, very important work. It is time consuming work, which is challenging. It can certainly derail your clinic if you are having that experience, but it is very important because we don't want people to not get the care that they need. Okay, I'm trying to blast through this because I always talk for too long. So case 2. So this is a patient who presented directly to the clinic. So L is presenting to discuss menstrual suppression and a desired IUD, and also has a history relevant for sexual trauma. This patient, when they come into the clinic, they identify as non-binary. They do not participate in penetrative sexual activity, and they are not up to date with health maintenance screening, but they are open to getting an IUD today or on return. This is something where I am going to require more time in this visit than I have allotted, and that is important because I need to make sure that I get as much information about their trauma history as possible to make them feel like I have the information I need to provide good care. But again, does not have to be a full disclosure. I don't want to make this patient uncomfortable. I don't want to ask invasive questions that are not going to help them receive the care that they need. But it is important for me to know that they have trauma. Sometimes it can be important to know, was this a stranger? Was this a trusted family member or friend? Because we're trying to establish a relationship of trust. So inevitably, in the back of somebody's mind is that nuance of, you're supposed to be somebody that I trust, but in the past, I have been let down by people that I trust. And that could be a really challenging barrier for your patients to be able to access you and then accept what you have to offer. And also knowing that a patient doesn't participate in any penetrative sexual activity, that has potential on top of a trauma history to make a speculum exam very challenging. A IUD requires a speculum. A PAP screen doesn't necessarily require a speculum. STI screening doesn't, but an IUD does. So we need to work through those nuances of, if you want to have this done today, we can absolutely do that. I can talk you through that, but there are certain options we don't have available to us if we do this here and now. Whereas if we return, we do have those options. So, same thing. We're going to validate the prior experiences that they have had. I can totally understand why you haven't had health maintenance screening based on your history. I don't know that I would have done that either. But the most important thing is that we keep you healthy and we keep you safe, and that you have access to all of the health maintenance screening that you should, because you deserve that. As a member of the community, healthcare is a right, and you have a right to have all of this, and we want you to have this. This is how we keep you safe and healthy. So these are the things that we have to offer. Asking about preferences. You can do your PAP collection, you can do your STI collection. You don't need to do that today. You can do that another day. You can come back. You don't even have to see me in order to do that. But having never had that done before, if you're more comfortable having a provider do that, I would be more than happy to do that for you here today and walk you through that experience. And then being transparent. I never tell anybody that having an IUD is not going to hurt. Realistically, it hurts, but it is brief and it is worth it based on what you're trying to achieve. And so just making sure that you are not letting people down by being like, oh, it's no big deal. And then it's a big deal. And then they don't trust you anymore. So we need to be honest. We need to be transparent about what we're doing and what that experience will be like. Again, we talked about offering choices. You can do this today or you can come back. You can have an anxiolytic if that's going to take the edge off, or not, if it's going to make you feel like you are not in control of your situation. If people have had experiences where they have been drugged in the past, we do see that, for any type of sex trafficking or assault, oftentimes there are drugs involved, then they may not want something like an anxiolytic or something like Valium, because then that makes them feel like they are kind of having that out of control experience. And so we just need to be mindful of what works best for people. And then ensuring that affirming environment, making sure that people understand, okay, in this clinic, here's the care that we provide. All of these people are choosing to be here, whether it's the front desk staff, your MA, the nurse, the student. This is an elective course. This is not required. Students who are doing this are students who want to learn this. All of that kind of stuff can be really, really helpful to making sure people feel like they can access healthcare, not just one time, but that they can come back. And that's important as well. There are often times where you're going to be setting the stage to make sure that people are willing to interface with a healthcare provider again in the future. So in real time, what you're going to do in these clinic settings or in any type of setting, any type of interaction, is you can ask. When you need to do something or even collect information, you can ask permission for that. I would really like to talk about if you have a trauma history. Is that okay for us to talk about today? That's important to the type of care that I'm going to provide you today. And I want to make sure I have this information so that you feel like you're in a safe space. And be patient. This is hard. The healthcare system is not designed for patience. It is not designed to provide time. We all understand that as healthcare providers, time is money. So the more time you spend with one patient, the fewer patients you see. So our schedules are not built to allow for time. They are built for efficiency. And there are going to be some patients that need time. And so when that happens, it is worth it. It is worth it because you want them to come back. You want them to feel safe. You want them to access the healthcare that they deserve. Asking patients who they would like in the room. Again, if they identify that they want to be alone for exams or procedures or questions, perfect opportunity to make sure that they're in a safe relationship and that they are supported in their most intimate home environment. Explaining what you'll be doing and and then explaining ahead of time, and then also narrating the actual procedure. And I do ask people ahead of time if they want me to narrate, because there are some people who are like, no, I'm going to put on my headphones. I'm going to distract myself with this, whatever I'm doing. And I just want you to do it. And I'll be like, okay. And so I'll kind of work out those details of, do you want me to tell you if something's going to be painful or just do it? And then kind of let them guide how they want that to go. And building rapport, being mindful of that power imbalance. That's why I say, listen, this is our first time meeting each other. Let's just get to know each other. I want you to be safe in this environment. I want this to be a familiar place. I want mine to be a familiar face before we do anything that feels invasive. So if you don't want an exam today, you don't have to have that. We can kind of level the playing field here and just collect information and exchange information here today. But also Be ready for a disclosure. Again, that is hard. It is hard when we don't have necessarily time built in to do that for every single person that we encounter, and recognizing that you may be caught off guard and you may not have all the resources that they need for help. I'm very lucky because in my setting, we do have that time. We do have resources literally sitting at the next desk. If they need to talk to a social worker about resources, if they need to be plugged in for mental health support right away, that doesn't mean they're going to get an appointment right away, but we can provide that next step follow-up immediately. And I know not everyone is in a setting or in the position to be able to offer that, but being ready for a disclosure and just saying, this is really important. I am very glad that you shared this with me because we do have resources, and it may not be something that we can put the wheels in motion right here, right now, but I want us to be able to help you work through this. Like, you deserve to receive the care that you need in order to be able to work through this, and we want to do what we can. So being ready for those disclosures, not dismissing it, not just saying like, I'm so sorry, that sounds like it was awful. Tell me about your family cancer history. Like that's just going to shut people down immediately. And then tailoring your care in a way that you can be sensitive to a patient's need for control, difficulties with that disclosure, difficulty with certain level of detail, which is totally fine. And then just the discomfort that comes with being vulnerable to a stranger, taking your clothes off, being examined. That is very, very hard. That is hard under the best of circumstances. It is considerably harder for people who have had a trauma past, and can be very re-traumatizing, even in a setting where they can say in their rational brain, I need this. I need a breast exam. I need this tissue to be examined to make sure that it's healthy. I need a pap screen. I need STI screening. I need a colonoscopy. All of these things. Your rational brain can tell you absolutely, but your subconscious brain is saying absolutely not. And so we need to do what we can to help people kind of get through that. So again, to review, you can optimize your environment. You can review your policies for gender inclusivity in the area that you practice. And if they don't have any, it's worth kind of saying like, hey, this is something that we should have, and this is something that we should make visible. Updating intake forms, that has been huge for us, changing the language on intake forms to make sure people can answer questions fully and feel like it's not particularly invasive and they're not having to disclose more than they wanted to. But so that we can get the information we need to make sure we're taking care of them. Ongoing staff training, making sure that those opportunities are visible and they include everyone, that you show up as a team. Building partnerships with organizations in the community. We have some great partnerships with Forge and with the LGBT Center downtown, and just making sure that we kind of stay in touch with mental health care providers across the community, things like that, to make sure that we have a network of people who are ready to provide care for patients who are already a part of a marginalized community as being members of the LGBTQ plus community, but also if they have experienced trauma, and then also minority oppression and intersectionality, they kind of all go together. And then collecting feedback from patients and clients, and just saying, what can we do better about this experience? And being open to that feedback is super important, because you're doing your best with the resources you have, with the time you have. And it feels really hard when someone is like, they did not take the time to do this. And you're like, I literally don't have the time. But just recognizing, okay, how can we change that? Can we make the rooming process shorter? Can we make the vitals happen at the end so that we have more time and we're not making somebody else wait? There are nuances to the way that we can care for people and interact with people that we might be able to modify if we identify gaps in our patients' ability to feel like they can receive good care from us. So key takeaways: LGBTQ plus individuals face higher trauma exposure due to systemic oppression, and then also that intersectionality. Trauma-informed care must be affirming to be effective. And so just kind of having that training, having that exposure, practicing what language you're going to use, making the fact that you're a safe provider really visible on your person, in your clinic setting, all of those things. Safety, respect, and empowerment are central to a patient being able to heal from past trauma. You saying you deserve better than this, you deserve good healthcare, you also deserve to be able to flourish in your life. So what can we do to help you grow through this experience? And then also providers play a really critical role in reducing re-traumatization by the way we approach visits and how we are going to verbally and physically and emotionally interact with our patients. So just things to think about, and I know we all have a lot to think about, but very, very important for this patient population. I'm not to it isn't about this, but also recognizing that over the past few years, based on our political climate, we all know that this patient population has really suffered in terms of access and what's visible in the media and how this patient population is portrayed in the media. These are significant challenges at, again, a systemically oppressive level. So anything we can do on an individual basis, I think, is really critical. And with that, questions.
Thank you so much. That was really, really good. I feel like I learned a lot. We have one question I'll just answer for everybody. Will this presentation be available as a recording? Yes, it will. I upload it to YouTube and then send y'all out a follow-up email which has the recording. Um, for those of you who want to make sure you are notified about other trainings we have that are trauma-informed care related, that QR code is how you can learn more about MTITC. And then my colleague, Dr. Kara Berg-Ronick, is the director of our Midwest Trauma-Informed Training Center. You can email her as well. And you can sign up at updates@hcet.org. If you just put in the subject line, sign me up for MTITC or MTITC, please, they will sign you up for the right one. If you would please go to the next slide. And then this is our eval. We would really appreciate you just filling it out. It's short. Our evals, if you haven't filled one out in the past like 6 months, are much shorter than they used to be. Oh, thank you, Brittany. Yeah, we're really, really glad you could come. And we'll hang on for a couple seconds and wait for some more questions to come in. I have one in the meantime. I'm
Sure.
thinking about organ inventory and how that might be really hard, especially depending on like a person's level of education. Is there a way, like, let's say you have a new person coming in and you are only like visually seeing them and you may not know anything about them. Like, how do you approach an organ inventory with someone that you don't even know at all yet? And let's say maybe they even they haven't done the pre-check-in on MyChart or whatever
Yeah.
tools that you have available.
Yes. So I think that would be, so let's say they show up, you have no information about them whatsoever, and you just see their name. That's all you know, and they're establishing care. So in that instance, I would walk in the room and say, "Hi, I'm Dr. Francis. So great to see you today. You can call me Jessica or Dr. Francis, whatever makes you the most comfortable. And how would you prefer that I address you?" Fantastic. This is your name. And can you tell me what are your preferred pronouns? And then I can write that down. And so then I'll say, okay, I don't have, we're new to each other. I don't have any information about you. So I just want to make sure that I get as much history as I can. So let's walk through this together. So we'll talk about medical history first, any healthcare conditions, blah, blah, blah. And then talk about surgical history. So asking about surgical history, then it's kind of I wouldn't say it's like an easy segue, but just say, okay, great. You've never had any surgeries. Can you tell me, were you born with breasts? Were you born with, those types of things? It is also reasonable to say, okay, have you ever had periods?
Mm.
Or have you ever had monthly bleeding? That kind of thing. So you can kind of get a sense just from asking some of those basic questions about like sex assigned at birth. And
Hmm.
if you feel comfortable enough, you can say, can you tell me what is your sex assigned at birth?
Hmm.
Now, I understand that might not necessarily feel comfortable for everybody. That I'm in a clinic environment where I'm very blessed that it does feel comfortable saying that because people know what clinic they're coming to. But if
Hmm.
you're just in a general primary care clinic or a general OBGYN clinic, you may be like, this could feel confusing for a patient as to why I'm asking this, but even just
Hmm.
saying, can you tell me what was your sex assigned at birth? And if they say, oh, female, and you can say, okay, and what is your current gender identity? Do you identify as female? Do you identify as trans male, non-binary? And you can give a list of options. And then that
Hmm.
also kind of gives you a baseline of, okay, if I know that they were assigned female at birth, these are the organs that should be in place, and kind of run through your surgical history and your organ history. And sometimes people might be like, why are you asking me all these questions? Especially if they are not a member of the LGBTQ plus community, but you're just trying to get this information. That's where it helps to say, we want to make sure that you get screening for any body part that we have screening available for. So that
Hmm.
means breast tissue, that means cervical tissue, that means for, making sure that we're screening appropriate sites for sexually transmitted infections and for prostate and all of those things that we kind of talked about. So just kind of framing it as we want to collect as much information as possible so that anything that needs to be cared for, we are coordinating that care.
Hmm. Okay, that makes sense. That's helpful because I was thinking, how do you ask about that? People,
Yeah.
depending, like, no, I don't know what body parts I have if I, maybe didn't go to university or whatever. But
Right.
so you say
Yes.
cervix, nobody knows what that is.
Yeah, one of my best friends, an educated, she has a college education. She always jokes with us and tells us like she did not know that there were separate openings for urine and menstrual blood until she was in college. And she was like so embarrassed that her parents never told her that. And she's like a well-educated person, you know? So again, we can't make any assumptions about what people know. So sometimes you just kind of have to be creative in the way you approach those conversations, but then recognizing that some people may find that offensive and like, why are you asking me all this? And
Yeah.
just framing it as we need as much information as possible so that we are taking care of everything we can take care of in your body.
Yeah, that makes total sense. I'm sure a lot of this too, you get better at asking with practice, right? Like
Yeah,
how
yeah,
you see what
yeah.
people respond to. Yeah.
And it can be very hard too, because I have so many patients who are specifically for our trans patients who have had surgery. They have had surgical interventions so that they don't have to identify as being trans anymore, right? And
Hmm.
so they're like, no, I am a woman. I don't want to be identified as a trans woman. I am a female. And they've gone to great lengths and great hardship and had significant surgical intervention to be identified as such. And so we need to make sure that they know in a healthcare set, you don't have to tell anybody else in this entire community, in your entire world, but in a healthcare setting, I want to make sure you feel comfortable enough to tell me because we want you to have a long, beautiful, wonderful life. You worked really hard to get here. We need to keep you safe and healthy. So that means I need to know, is this a neo vagina? Because you may need dilator therapy, you may need estrogen therapy, you do still have a prostate, like all of these things. So you don't have to tell anybody else. This is for us. This is for our
Yeah.
relationship so that I can keep you safe and healthy and you can enjoy a long life that you have worked really hard to create. So
Yeah.
just making sure people feel that you are working together, not just collecting information.
Yeah. I can see I had a friend who he didn't know that he still needed to have like a breast tissue exam after he
Mhm.
transitioned. That was really hard conversations. I can
Yeah.
just imagine like I would be like trying to Google like how do I talk about this with this patient? And
Yes. Yes.
that's
Yeah.
really tough.
You know, it's tricky, but again, like I said in the beginning, our patients understand that people did not get formal education. That is a very new thing that's starting to be integrated into undergraduate and graduate medical education and training programs. So if you are like open with your patients and you acknowledge if you misgender somebody or use a wrong pronoun, you just say, I'm so sorry. I'm going to write this down. I'm going to make this visible in your chart. I'm not going to do that again. You know,
Hmm.
and if you just acknowledge and they can see that you are working hard to provide good care and you're not just dismissing them, people are very gracious.
Yeah.
People are very gracious. They understand that there's not a formal curriculum for this, and even what little there is, not everybody gets.
Right.
So,
Yeah. That makes total sense. I'm
mm,
just checking to make sure. Oh, good question. So did Sal return to the clinic after the colposcopy?
yes.
We're all invested. Okay, yay.
Yes, which is really fantastic. And the other good thing too is that Sal has continued to get multidisciplinary care through our clinic, which includes mental health care to work through past trauma. Because you don't get over trauma. Ideally, you work past it and are able to establish healthy adult relationships and trusting relationships, not just in a healthcare community, but on a personal level as well. So it was really good that Sal approached the phone call that way because immediately it told me this is important, right? Like he's telling me this because something important has happened in the past. And usually it's not just the pap, right? Like paps can be very off-putting, let's all be honest. And so sometimes like, oh my God, that was a terrible experience. It was really uncomfortable. But if there is something deeper, we need to know that. So Sal approaching it that way gave me the opportunity to get more information and to get him plugged in with more comprehensive multidisciplinary care. And in the end, he recognized that other provider wasn't trying to do him a disservice, still a good provider, all of those things, but just that he needed more nuanced care in a different setting. And we're lucky that we have that to offer. So
Yeah. And I bet, I don't know, I'd be like petitioning my admin to please give us a traveling colpo machine or
oh
whatever.
my gosh, I know.
It's
Yeah,
expensive, I'm
yeah.
sure, but
Yeah, I know, right? Well, yeah, there's so many logistical barriers there in a healthcare setting, but we were able to navigate that. So
yeah. Well, that is wonderful. Thank you so much for your
Yes.
time and sharing
Yes,
your
you're so
experiences.
welcome. Thank you for being
Yeah.
here. I appreciate it.
Yeah. I
All
really
right.
appreciate you too, like sharing your missteps. I feel like providers
Yeah.
need to talk about that with one another. Like we can, I say we, I'm not a provider, but like, people in general
Yeah.
need to
Absolutely.
learn from
Absolutely.
their
Nobody,
past.
nobody, nobody nails it the first time every time. So it's good that we all know, and can share how we made improvements. So
Okay.
that's a
Awesome.
good
Yeah, you
thing.
just have lots of compliments in the chat.
Oh,
So
well, I
we really
appreciate it.
appreciate
Thank
your
you.
time and have a wonderful
Great.
rest of your day.
Thanks, you as well. And I'll look forward to seeing you this summer.
Yeah, actually, I'll just say it out loud because maybe not everyone has the announcement yet. Dr. Francis is doing another talk with us this summer in July. I think it's like July 28th, but I'll get you the information for sure, th those of you here listening, on trauma-informed care for pediatrics. So, yeah, we'll talk about working with young people, young adults, adolescents,
Yeah,
the whole thing. Thank you,
perfect.
everyone.
All right. Thank you. Appreciate you all. Have a great day.
Bye.
Bye bye.